It's nice to be back. Always nice to butt heads with the bright young future. The thing that I think that's really most important to keep in mind when we talk about this debate, it's really not about anything more than survival, right? So PFS and OS are the single most important issues that we need to remember as we discuss this question. What I do want to remind everyone of the whole idea about sometimes improving the depth of our response is at a significant cost. And while I don't have data to show, CLGB did a study a number of years ago looking at fludarabine Rituxan with the addition of alemtuzumab to bring patients into really deep remissions. And the patients who achieved a CR to FR and then got alemtuzumab all died of infections. Not all, but most, 5 out of 7 died from infections. And those people who achieved PRs actually did quite well when they got the alemtuzumab. So it's really very important to keep in mind is what is the cost? And none of us are really talking about the costs unless we're talking about PFS and OS. So when you look at that, 30% tail on the FCR curve at year 10, we have to remember that 8% of patients died because of MDS and AML. And that really is, as we're going to hear again and again this afternoon, how little benefit or how little advances we've made in the secondary myeloid neoplasia groups. And so likewise, when you start talking about a mutated CLL population, which has an excellent prognosis, and all of a sudden you start talking about a 60% long-term survival, once again, that's still losing 8% of those people who could potentially have been still alive. So let's go on and discuss more of the details. Pointer all the way. Here it is. Thank you. So here are my disclosures. So, we always talk about the survival of CLL patients and how it looks like we really are doing markedly better over the various decades. And these are data from Michael Keeney and MD Anderson. And you can see here how the curves really are moving up and really looking very optimistic. But the truth is, and these are data from a different subset. So these are data from a European group, Stefan Malika, looking at their patients by Binet stage. The real advance in overall survival that we've seen with CLL patients over these decades really is related to lead time bias. So we're diagnosing patients earlier, more and more patients in Binet stage A, and when you look stage by stage, there's been no increase in survival, with the exception of Binet C. Now, these are data that were actually cut in 2005, so I really suspect that we're now dealing with a very different scenario, but these are the data that we have from the eras of chemotherapy. So looking at our novel agents, and I'm really going to just focus on the BCR antagonists, and ibrutinib in particular for today because for the interest of time. But we certainly have the inhibitors of Bruton's tyrosine kinase, so ibrutinib, CC292, and AVL292. This drug is actually not moving forward in further development due to lack of efficacy. Acalabrutinib, or ACP196, and ONO4059. We have our PI3 kinase inhibitors, you can see there, idelalisib, duvelisib, and ACP319, and our BCL2 mimetics, namely venetoclax. So one of the things I think that's important to keep in mind is we've already gained a lot of experience with how these agents have changed the way we need to think. So we've had to refine our response criteria, we've had to refine our dosing, and we've had to refine our reevaluation of prognostic markers in MRD. So all of this is actually very obvious when we start talking about, no longer are we using an MTD to dose our patients. And since really almost everyone responds, prognostic markers really have to be reevaluated. But let's focus on the first and fourth points. Looking at response criteria, our response criteria really are supposed to be a measure of efficacy. Really supposed to help us identify who are those patients that need to stay on therapy, who should stay on therapy, and those patients who need to be coming off therapy for lack of efficacy. So the first patient to receive idelalisib in the phase 1 study was actually taken off trial because the white count rose after getting idelalisib. So you can certainly appreciate how big of a mistake that was and how important it is for us to learn about how we should expect these agents to behave. So what we have done basically is a committee was convened by the Lymphoma Research Foundation that reevaluated the endpoints for CLL patients. And included in that is the idea that a lymphocytosis in and of itself shouldn't be grounds for calling a patient having progressive disease. All right, so we've learned about these new issues and caveats that we have to keep in mind. All right, and so here's an example of the lymphocytosis that we see with ibrutinib, and you could see that in essence, all of these people here would qualify as having progressive disease and of course be off trial, but that would be a tremendously unfortunate aspect. You can see here that the lymphocytosis, which peaks at 4 weeks, can actually extend out to 136 weeks. So, and I'll show you more data biologically about this later on, but even the duration and the persistence of this lymphocytosis, which is described as having a return to baseline. So we're not even talking about normalization of the lymphocyte count, but a return to at least just the baseline in these patients, don't indicate necessarily a poor outcome. And so it's really very obvious here that, an endpoint really has to be predictive of how people are going to do long term. So looking at the other question then, which is how do we know when to evaluate our responses? So everything we know about MRD is based upon chemotherapy. And you could look after 3 cycles, you can look 2 months after 6 cycles like the German CLL study group did in their 4 and 8 trials, and I'll show data from that in a moment. But the question is, with our BCR antagonists, our responses evolve over time. And we have patients who are really having stable disease, which will include the PR with lymphocytosis, become PRs, and our PRs become CRs. So if you were to look at the data here and take a very early cut, you would get a very different answer than if you were looking out here. And with that line also comes a question about, well, if you don't know when to look at your responses, or if the responses are going to continually improve, when are you going to look at MRD? Are you going to say MRD at 12 months, or are you going to say MRD at 24 months? And what really is most important is when you start talking about MRD is what does it translate into? So here are the data from the German CLL study group, CLL8 study, showing that the MRD level actually predicted very nicely, and that's this table here, for the duration of response. All right, so these were everyone getting 6 cycles of FCR or FC, and then regardless of which therapy you got, the depth really predicted on how you did long term. And looking actually here at the ability of using MRD as an endpoint to help as a surrogate endpoint, we're able to see that the better therapy was able to achieve a better MRD outcome. So with regard to chemotherapy, this is very relevant. But we're done with chemotherapy, and no one should be getting chemotherapy. And I criticize my colleague for actually putting a combination trial of FCR and ibrutinib together, because why would you want to damage the patients with the FCR chemotherapy when it's really not going to enhance the response at all? So MRD really needs to be reevaluated as an endpoint in the context of our new agents. What I really think is a good idea to keep in mind as a demonstrative example is the idea that if we were to take patients who were MRD negative 2 months after FCR and to give them ibrutinib and they became MRD positive, would that really be a bad thing? And my belief is it's not. We're mobilizing the cells out of the niches. This isn't progressive disease. This is just putting the cells, the CLL cells themselves, at risk of apoptosis, which is our ultimate goal. So looking here at chemotherapy and whether or not this idea of using response rates to predict long-term outcome, what I'd like to point out is these are data from the German CLL5 groups, the German CLL study group CLL5 study, looking at chlorambucil plus fludarabine. And you can see fludarabine definitely demonstrated a marked improvement in overall response rate, slight improvement in complete response rate, and improvement in partial response rate. But when you look at overall survival, which is really what is most interesting to our patients, there's no benefit. And a lot of the cost here was just in the toxicities of the chemotherapy. So no, not always. Responses don't always indicate the benefits that are going to be derived from our therapies. Now, looking at the 1102 study, so this was the ibrutinib phase 2 study, which included treatment-naive and relapse-refractory patients. What I really want to focus on here are the treatment-naive patients. And you can see here extremely high response rates, but very few complete response rates. And these are actually 3-year data follow-ups. So these are data that keeps getting updated. And the numbers do keep changing, as we showed earlier. But what I really want to emphasize here is among the patients who achieved a PR with lymphocytosis, patients who would, by the IWCLL criteria, be considered progressors, 11 out of 13 did go on to achieve responses. And the question, of course, is one day that might be 13 out of 13, because remember that lymphocytosis does persist for up to 104 weeks. And so here we are talking about, 3-year data, and there are some patients who are not yet out that 104 weeks. And looking at the swimmer's plot, and this is now once again the treatment-naive population over the age of 65, you can see here that the vast majority of people continuing on drug are still just partial responders. And so the question is are you going to say that your response isn't deep or your response isn't MRD negative and we should do something differently? Or are you going to tell these patients that we should add something like FCR to make them MRD negative and add the risks associated with that for no real apparent clinical benefit? And what I'd like to point out from here is really the patient disposition on the 1102 study. And you can see in the treatment-naive group, really there's only been one patient who had progressive disease. And you can see this actually was a patient at month 8 who developed a Richters transformation. Ostensibly, it was there before the patient went on study. This was the 117p deleted patient on the treatment-naive curve. So yes, we're dealing with a group of treatment-naive patients who had good prognostics, but no one has progressed on ibrutinib with a median follow-up of 36 months. Or 30 months, I'm sorry. And what I'd also like to mention here is in looking at the persistent lymphocytosis, so Jennifer Wowach did some very nice data, or generated very nice data where she took patients who hadn't had normalization of the lymphocyte count by month 12. And she looked to see whether or not there was any differences biologically and clinically in these patients. And what she showed is even at month 12, BTK was still fully inhibited, the pathways were still fully shut down, and there was no difference between 3, 6, and 12 months biologically in looking at the cells. And using a landmark analysis starting at month 12, you can actually see here that the patients who had a prolonged lymphocytosis, no one's actually progressed, which actually differs from the group that did qualify as having a response. So here, arguably, once again, using PFS as the more important indicator of how or what's important to our patients, we have data supporting not using responses, but using or just continuation of therapy in these patients. And what I'd also like to point out from this is that the most important indicator of the duration of lymphocytosis turns out to be the immunoglobulin G mutational status. And what you can see here are the patients from the 1102 study looking at the mutated versus the unmutated patients. And you can see here the duration of lymphocyte, the number of percentages with lymphocytosis, the numbers that were normalized, and the median time to normalization. And you can see here, if I can get around my colleague, if you can see here you can see here the duration of the relative percentages with the lymphocytosis at various time points. We all know that mutated immunoglobulin genes is a good prognostic marker, and these patients do exceedingly well. And if you give them FCR, except for the 8% you kill with secondary myeloid neoplasias, you can actually cure a significant number of them. So lo and behold, they tend to be the ones that respond slower. So this is really a very demonstrative example of how in the era of our novel agents, the responses really don't matter. I hated to do this, but I felt like I had to do it. And I guess since we're not voting, it's okay to move forward with this because I won last year, but let's, focusing on this year, I'm going to throw myself under the bus. I do want to point out 2 very important exceptions. And the thing that I find is sort of the greatest obstacle to CLL patients going forward is really going to be when their CLL either stops responding to a BCR antagonist, all right? So this should be BCR antagonist resistance, or our patients transform. And as long as we avoid that, we really have so many options for controlling our patients' disease. And so these are really the 2 things that I worry about in all my patients. And data that we generated from the 1102 study, looking at all the CLL patients who actually had been on drug for more than 12 months, and then looking at those who progressed. So we have these 20 patients here. So we had 13 that developed Richters, and then 7 who developed resistance, all right, with a specific genetic mutation. So we really, have a very small subset of patients that are definable as the ones that are going to not do well. The ones who develop the resistance are the ones who have very high-risk genetics. So 17p complex karyotypes, and we're going to hear a lot more about the importance of complex karyotyping in terms of prognosis in the future. But these are the ones that have the genomic instability to develop mutations and become resistant. So looking at these patients, and then patients who either have like Notch1 mutation and have an exceedingly high risk of developing a Richter's transformation, or certain V gene families like 4-39 that have also an exceedingly high risk of developing a transformation. With these definable patient populations, yes, we might need to do something differently. But in everyone else, really, I think we've done almost all that we need to do. Thank you.